right, thank you. I'll be presenting on the prognostic and predictive value of PET biomarkers. I don't have any commercial conflicts of interest. I'm supported as a PCF young investigator from last year, as well as support from ANZA Below the Belt grants. So almost a year and a half ago, we published on the PET biomarkers from the therapy data in Lancet Oncology. And we found some quite striking results. Everyone is quite familiar in this audience with the therapy trial. We met primary and secondary endpoints, primary one being the PSA 50 response, and secondary mainly for the PFS. And everyone knows about the FDG and PSMA that was used for patient selection. So you needed a high SUV max greater than 20 versus vision greater than liver, and you needed to have FDG, no discordance on FDG PET scans. So we randomized a 1-to-1 ratio, 200 patients. They received either cabazitaxel or lutetium PSMA, and essentially, our hypothesis was that PSMA PETs done before the treatments will be predictive. We'll be able to identify patients who have a higher likelihood of an outcome to a specific treatment, in this case, lutetium PSMA. We have a strong supporting rationale, so we think that very high uptake, you'll get higher dose delivery to tumors, and you'll therefore better responses. And it's very important to do this in a randomized controlled trial. Predictive biomarkers can only be done this way. You need similar characteristics between the arms. We also hypothesize that FDG will be prognostic. Whatever you do to them, regardless of the treatment we gave them, that they will do poorly with higher volume. This is how we did it. We have all of the prospectively collected PET scans. They were contoured by experts, SUV greater than 3 for the PSMA PET, based on liver for the FDG. And the biomarker, the thresholds that we had were all pre-published from the initial cohort of lutetium PSMA. So if you had a PSMA SUV mean greater than 10, that's very high uptake. And we identified FDG volume in that initial analysis as well. If you had greater than 200 milliliters, then you should do poorly. So this was well balanced between the groups, roughly 30% in each arm. And you can see the waterfall plots here. This is for one of the co-primary endpoints, PSA response, so greater than 50% drop. This is showing the patients in each arm, cabazitaxel to your left, lutetium to the right, if you had an SUV mean greater than 10. So you can see that patients did remarkably well with lutetium. There you go. 47% with cabazitaxel had a PSA drop more than 50 versus 91% for those receiving lutetium. And interestingly, they had very much deeper responses as well with lutetium. 60% of them had more than 90% drop. When you look into those with lower uptake, they still did better with lutetium PSMA, but by a lower magnitude, 32% for those who had cabazitaxel to your left versus 52% with lutetium to the right. This translates into very high odds ratios for those who had a high SUV mean, 12.2 versus 2.2 when you were in the lower uptake group. And this was significant, so we had higher PSA intensity, leads to better responses with lutetium PSMA, and very high, it's a significant p-value. We did a post-hoc sensitivity analysis as well, dividing into 4 thresholds. You can see 2 beautiful examples, one to the left, that lower extreme, low SUV mean, 4.9. Everything's a little bit gray. You're probably not getting much radiation in most sites, and you have a few darker spots that stand out, so you meet that 20, and to the right, just this exquisitely high uptake throughout. Those 4 quartiles, you can see with cutoffs of 6.9 SUV mean, 8.5, and greater than 10.8. And you can see on the second row that you had increasing responses as you went higher up into those quartiles. And it was predictive for response in those 3 top quartiles. You would do better with lutetium PSMA. In the lower one, the p-value was not significant, though likely underpowered. We can't determine if one was better than the other. For FDG volume, prognostic biomarker, these are all patients grouped together. If you had high volume to the right, more than 200 milliliters versus low volume to the left, you do much better with low FDG volume, 56 versus 38, regardless what you give them. This translated into also significant findings for the co-primary endpoint. So we had still would do better with lutetium when we break it down, as you can see. But if you had a lower volume, you do much better than high volume. And this would lead to an odds ratio of 0.44 and a significant p-value. FDG volume is also prognostic for the rPFS. You can see a very nice separation of the curves here on the Kaplan-Meier plot. In blue, the FDG volume that is lower. And I want to update on the overall survival paper that we just published a couple of months ago now in Lancet Oncology. I won't get into the details of the main results, but the survival was similar between both groups. You can see this is the Kaplan-Meier, and there's also these the restricted mean survival time, which go have a read of the paper. It's very interesting if you'd like. It's roughly 19.1 versus 19.6 months, so there was no significant difference. When you break it down, we did test for OS. So is PSMA SUV mean prognostic, and is it predictive for overall survival? We found, interestingly, that it's not predictive, but it is strongly prognostic in both arms. So you can see there's also nice separation of the curves for overall survival. The sensitivity analysis didn't identify any better thresholds. And this is for FDG. You can see that it's strikingly prognostic. These are all patients together. This is cabazitaxel to the left, lutetium in the middle, and all patients to the right. And a drastic separation of the curves here. So it is prognostic in addition to other surrogate endpoints like PSA response and rPFS. So we can stratify remarkably well, and I like this graph so well, I'm going to pause and have a look if you want to take some pictures. All right, that's enough. I don't like showing tables necessarily, but we did also adjust for conventional imaging biomarkers to make sure that it is very good, but is it better? Does it add anything to the conventional ones? The answer is yes, it's actually remarkably high. The hazards ratio of 2.1, the most strongly significant prognostic biomarker. And this is the sensitivity analysis. You can probably even pause for this too. It's a really nice breakdown. It's in the subappendix, and you can see by group the lower volume in red going up to the higher volume in purple, and a beautiful separation of the curves even with very low numbers. And what about vision? I think that's one of the main questions that we have. This was presented by Philip Kuo at EANM in 2023, just last year. A sub-study for biomarkers as well. You can see they split by quartiles and also identified SUV mean roughly of 10 also as a significant biomarker. Nice separation for overall survival, as you can see to the left. The right is just the standard of care where you don't see any clear differences, obviously, but to the right, those treated with lutetium PSMA. And when you have a look here, this is I think this is quite interesting. You can see they plotted the SUV mean cut points. So to the left, rPFS, to the right, overall survival. And you have the hazards ratios on the y-axis. And you can see that there is a very nice gradual improvement, strikingly high hazards ratios as you get to the right in those really high SUV means. Two things caught my eye looking at this. The first is that the y-axis isn't quite the same. I'm a fan of trying to represent data as best possible. I think that it was a little misleading, so I took the liberty of redrawing it for them. You can see here when you bring it up to 1, it's actually strikingly high for rPFS. You have really beautiful hazard ratios across the board. SUV mean is prognostic for rPFS and OS. And the other thing that caught my eye is that here we have SUV means of 5.6 to the left, but they're not there for SUV mean for overall survival. And what happened to those patients? We know we have data for rPFS. When we have a look, SUV mean greater than 7 was those top 3 quartiles in therapy. And when you have a look at vision, the median is actually quite close to 7.5. So there's half the patients that are omitted from this graph, or not represented as well as we would like. I wonder if, would those hazard ratios actually be around 1, across 1? I think that's, we don't have the full picture yet. So essentially, we have very strong data now from both vision and therapy supporting that PET biomarkers are prognostic and predictive. Randomized studies, therapy had FDG, which is highly prognostic. This was all pre-specified, so very high-level statistics. Weaknesses, took out the OS now. We have that data, manual contouring. I think that the next step is how can we apply it in clinic. We need more AI, and we have no information about that lower uptake. And finally, the quantitative parameters are useful, very high. You should prioritize lutetium, probably as a monotherapy even. But when you have low uptake or high FDG volume, it begs the question, what other strategies, what other targets can we look for? Combination treatments, we need more research. I'll just leave you with the take-home messages here. Essentially, high PSMA expression is predictive for PSA response. It's prognostic for overall survival. And the high FDG volume is prognostic, so you have worse survival, worse PSA response, as well as RPFS. Thank you.